Please listen carefully.
Hello and welcome to GasGasGas. This is the best podcast for the FRCA primary exam. Our goal is to fill your brain with all this highly useful information. You might be in the gym right now, commuting, or ironing your scrubs. Regardless, the revision is eventually going to end, but for now, expect facts, concepts, model answers, and the odd tangent. Make sure to check out GasGasGas.uk. The show notes there's loads more detail. Make sure to like and subscribe. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. Hello everyone, welcome to GasGasGas, the podcast designed specifically for anaesthetists in training, that's you, hopefully. I'm your host today, James, aka Dr. Gas, and today we are hopping off of that 10-metre board, diving into a big swimming pool that's sufficiently deep enough and full of Prilocaine. So this is a local anaesthetic that we probably don't think about very much because it's overshadowed by lidocaine, but it certainly carries use in your anaesthetic toolkit. So whether or not you're preparing for your primary FRCA exams or just starting off in anaesthesia, understanding Prilocaine means that you can have some interesting conversations with your trainers about timing, dose, etc. and the logistics of running a day surgery list using spinals. We're naturally going to talk pharmacodynamics and pharmacokinetics and explore the dosing strategies for these day case short-acting spinals. Openly for me, when I was first starting out, the thought of using a drug that doesn't last as long seemed quite unsettling because naturally, what if something goes wrong? What if the surgeon takes ages? What if there's delays in getting started because they can't find the appropriate kit? So we're going to talk a little bit about the dosing strategies for Prilocaine and also patient selection. I just wanted to take the quick opportunity, guys, to thank those folk who have actually donated to the show. Really appreciate it. It does make a valuable contribution, both to general costs, but also it is super validating, guys, so thank you. I'm trying my best here, and it clearly has value to you too, so thank you very much for those donations so far, folks. There is a link in the show notes if anyone else has cash burning a hole in their pocket. But if they've got loads of cash burning a hole in their pocket, then I would suggest donating to the BMA Strike Fund. And Dr. Gas is pro-strike, but this is an apolitical podcast, at least we try to be. So let's get on with some Prilocaine. I'm sure the first question that jumps to your mind, and it certainly jumps to my mind, is why are we messing around with this other drug called Prilocaine? Why don't we just use lidocaine? That's because actually, unfortunately, lidocaine is a massive offender for TNS, or transient neurological symptoms. TNS occurs after spinal anaesthesia, i.e. intrathecal local anaesthetics. It can occur after the administration of any of the common intrathecal local anaesthetic agents, i.e. Bupivacaine, Levobupivacaine, Prilocaine, 2-chloroprocaine, and lidocaine. But what's the dealio? So there's a big Cochrane review that looked at oodles of patients, and the line from that patient that summarises it very well is, specifically, when alternative local anaesthetics were compared directly to lidocaine, the risk of developing TNS was reduced by between 82% and 90% when Bupivacaine, Levobupivacaine, Prilocaine, Procaine or Bupivacaine were used rather than lidocaine. So you can understand that means no one's going to bother sticking lidocaine into someone's back when there are other choices. What is TNS, you ask? Right, TNS is something that tends to present 24 hours after doing a spinal on someone. They get buttock pain and they get pain down their legs and dysesthesia, so altered, unpleasant sensations, lasting for up to 7 days. It's naturally transient, it's not lasting, but lidocaine is a big old offender for that. Another study before this Cochrane review found that up to 40% of intrathecal lidocaine administrations led to some degree of TNS problems. So there we go, folks. Don't use lidocaine. Instead, use Prilocaine, which is what we're going to talk about now. Great! So Prilocaine is another one of our friendly amide local anaesthetic drugs. Its full chemical name is Prilocaine hydrochloride. Amide local anaesthetic, and it's an amide derivative of toluidine. It is presented as a clear and colourless solution, and it's a racemic mixture of R and S Prilocaine, and classically comes as either a neat mix, or for us, when administering spinals, you get it as heavy Prilocaine, aka Prilotecal seems to be the one that is in most drawers, and it comes as 1% 2% and 3% solutions. If I'm remembering correctly, our Prilocaine is 2%. It's got a molecular weight of 220 grams per mole. If that floats your boat. Pharmacodynamics of Prilocaine. Well, you can tell me, and actually you could probably take 30 seconds if you were to pause it to tell me exactly how local anaesthetics work. You could pause it now. Pause. You paused. You've unpaused, so you must have thought about it. Local anaesthetics work by sodium channel blockade, but they're mischievous and they only work on the inside bit of that sodium channel, and when I say inside, the bit that's inside the cell. Therefore, that local anaesthetic agent has to cross the neuronal membrane. To do that, it has to be unionized. But further mischief befalls us because only the ionized fraction, or the cationic variant, once it's inside the cell, acts to block that internal aspect of the sodium channel. So there's a few steps that have to occur. It's not just a magical jumps onto those sodium channels sort of drug. These events are governed by how lipophilic the agent is, how fat soluble it is, and the pKa of the agent, i.e. the amount available unionized that can jump across that gap. But we're going to cover that in a moment. Clinical uses, well, spinal anaesthesia, but you could also infiltrate it as a local anaesthetic if you so chose. Why would you choose to do that? Well, it lasts a bit longer than lidocaine, perhaps up to 1.5 times longer, and it is 33% unionized, and you can guess that that means that its onset time might be faster than lidocaine. So maybe we should be using it to do all our art lines and our central lines. Faster onset, no dilly-dallying being like, can you feel it? Perhaps that's a conversation for another day. So if you look at the show notes, I'm going to break down dosing in all the various areas. The important things to note is a toxic dose is considered 6 milligrams per kilo, and a maximum dose might be 400 milligrams. Well, I say might, it is 400 milligrams quoted. You could choose to use it for peripheral nerve blocks, infiltration at site, caudal anaesthesia, as well as epidural top-ups. Although I think most UK practice is limited to spinal anaesthesia and topicalizing kiddies, because EMLA is made up of Prilocaine and lidocaine, 2.5% each, and EMLA stands for eutetic mixture of local anaesthetic. Eutetic because it wouldn't be a gel if it was just one or the other, but mixed together it seems to behave quite happily. Go and have a read up about that if you want to know more about EMLA. Not really the focus of today's episode. Prilocaine is also used for intravenous regional anaesthesia. You probably just fell off your chair, crashed your car, or you've been slung off the back of a treadmill. Intravenous regional anaesthesia? Yeah, Beer's blocks. This is where you stick a tourniquet on someone's arm that is sufficiently tight, and then inject local anaesthetic to a sufficient quantity into the veins of that arm to numb it so that you can adjust a fracture. I'm going to put a link to the Royal College Emergency Medicine leaflet guidebook information contraption in the show notes for a bit of a further read. Not something that's done terribly often these days. I've seen it once when I was a medical student, and that was a while ago now. But anyway, it's kind of cool. So continuing on with our conversation about pharmacodynamics of Prilocaine, we need to talk about the side effect profile of Prilocaine. So side effects, as we know, are dictated chiefly by systemic absorption of that agent into plasma and then it tottering off to other sodium channels elsewhere in your human patient. In low concentrations, Prilocaine can push up your systemic vascular resistance, i.e. cause a little bit of vasoconstriction. However, as with most other local anaesthetic agents, toxicity leads to cardiovascular collapse, hypotension, dysrhythmias, etc., etc. In low concentrations, from a respiratory perspective, it can cause a bit of bronchodilation, but again, from a toxicity perspective, apneas and insufficient breathing become a problem. CNS-wise, we're going down that same route of CNS toxicity that we're described for our Bupivacaine episodes, and we're going to go into a deep dive when we do our local anaesthetic toxicity episode. But we're all about the primers in GasGasGas, and I'd like to dribble breadcrumbs throughout the whole thing so that you're getting more than just a bland conversation about the molecular weight of Prilocaine, which would make me just throw myself off the back of that treadmill. So what comes about in the CNS if you put local anaesthetic in someone's vein and it totters up to their brain? Well, it's biphasic. We mentioned that earlier. And that's because initial inhibition occurs to inhibitory interneurons. These are little neurons that are like the conductors in your brain, and they put the brakes on everyone else and only let them communicate just the right amount. When you inhibit those inhibitory interneurons, the brakes are off and your brain gets a bit more lively. This leads to lightheadedness, dizziness, and those sensory disturbances like visual changes, auditory changes, circumaural tingling, tinnitus, etc. However, as this situation progresses and the local anaesthetic soaks in further to the brain, you then end up in the state of sedation, coma, etc. This is why you might see a bit of seizure activity between these two phases. These inhibitory interneurons are also implicated in that seizure-like weirdness that sometimes happens with propofol, either because you've given a little bit less than you might normally and they get a bit lively and do something that looks like a seizure and then they're off to sleep, or if they're seemingly young. Kiddies seem to do it a bit more. They do a bit of a weird dance and then they're out. And it's because those inhibitory interneurons appear to be more susceptible to inhibition than the rest of your brain. And there's a chapter on it in Miller's Anaesthesia for anyone who's excited about interneurons, like me. So what about toxicity? So Prilocaine is less toxic than some other drugs, but it also has another complicating effect, which is in large doses, you can cause methemoglobinemia. And that's because a metabolite of Prilocaine has a proclivity for hemoglobin and it likes to oxidize it. And that metabolite, which might come up in an exam, is O-toluidine or orthotolidine. The treatment for methemoglobinemia is to give people methylene blue, 1 to 2 milligrams per kilo, and that tends to shift the hemoglobin back to an unoxidized state. But it also causes havoc with your SATS probe, and sometimes patients are allergic to it, and then you get a really weird urticarial blue blotchy patient, and you have no idea if they're hypoxic or not. That's always fun. Now, 600 milligrams is quite a big dose. That's 10 times the max dose recommended for spinals. So it's only really going to be happening if you're doing infiltration of Prilocaine in massive doses. You might be a bit more likely to have that problem if the patient is also on other drugs that tend to oxidize hemoglobin or predispose hemoglobin to oxidation, i.e. sulfonamides and all those fun drugs. And when we're talking sulfonamides, we mean things like sulfasalazine, that's used in IBD, and sulfamethoxazole, which is one component of Septrin, which is used for PCP and generally very poorly patients on ITU who seem to be getting to the end of the antibiotic road. Hopefully you got the gist of that, folks. And if you're excited by inhibitory interneurons, drop me a message. We can be excited about that together. Pharmacokinetics of Prilocaine. So absorption, well, it depends where you inject it. If you inject it somewhere where there's loads of blood vessels, you're going to have more absorption. If you inject it into somewhere that's relatively avascular, less absorption. So it follows that same structured absorption ladder that is described, which in order of highest plasma concentration evident to lowest. If you stick it in someone's vein, it's going to be high. Then tracheal, intercostal, caudal, epidural, brachial plexus, subcutaneous. It is important to remember that because it might come up as an SBA, which is associated with the most or the least absorption, blah, blah, blah. Prilocaine has a pKa of either 7.7 or 7.9, depending on what you read, and it is approximately a third unionized at physiological pH. So there's quite a lot free to get jiggy with those sodium channels eventually. It is 55% protein bound. Again, there's a higher fraction, and it has a tendency to bind to alpha-1 acid glycoprotein, which is not dissimilar to Bupivacaine, which also has a preference for that. It has a volume of distribution of 190 to 260 litres, but we're not really interested in sticking it in someone's vein and then measuring a concentration later, because that's madness. Metabolism of Prilocaine. It's an amide. Amides are metabolized in the liver. That's why they theoretically last longer. And it is metabolized via hydrolysis to that O-toluidine or orthotolidine, as it's otherwise known. And then that is hydroxylated to variants of hydroxytolidine. It's got an elimination half-life in the plasma of 1.6 hours, and you pee those metabolites out via your kidneys. So that's all well and good. We now know enough about Prilocaine to think about it in a safe and sensible manner, but how are we going to use it? Now, I'd hope on the wall of your anaesthetic rooms there is Dr. R. Erskine's excellent flowchart that basically tells you exactly what to do. There's going to be a link to that seminal paper in the BJA from Erskine et al., although it's not Erskine, it's someone else who got the first author. But there's also an excellent Block It Like It's Hot podcast episode where they interviewed Dr. Erskine and they had a lovely long chat. He works at the Royal Derby Hospital and he sounds like a pretty top bloke. So anyone who's working there, you're a lucky sausage. Anyway, it'll be on your anaesthetic room wall, but we're just going to go through it to try and make sense of it, because if you just look at it and try and understand it, I actually found myself a bit bamboozled, because it sort of works a bit back to front. It makes sense once you understand it. So the first question that comes up is, are you just trying to get a saddle block? Now, saddle block is where you're really just catching those sacral nerves. Patient's quite numb around the area where they would be wearing, some boxer shorts or some underwear, and it doesn't catch much else. So if you're aiming for that, you only need a tad of heavy Prilocaine, i.e. Prilocaine, 0.5 ml to 1 ml, 10 to 20 milligrams. So not very much at all. You inject it, you let it sink down and soak in, and let it fix. The important thing with Prilocaine is it does fix quite quickly. So if you're doing an injection and you don't want a saddle block, don't dilly-dally, lie the patient down. And even if they start trying to tell you about their cat, just grab their legs and swing them round whilst learning about their cat. So if you don't require just a saddle block, the next question to think about is, how high does your block need to go? Now, if you're aiming for above T10, that is above the umbilicus, then you need to give 3 mils of Prilocaine, heavy Prilocaine, and that's about 60 milligrams. And that will cover you for things like umbilical hernia, diagnostic gynae laparoscopy, i.e. looking for endometriosis, and then ureteroscopy plus minus stents and lasers, depending on how high up they're going with those stents. If they're fiddling around in the kidneys, might not quite cover it. So then you're thinking, well, no, I don't need a block above T10. It's actually a bit lower than that. The next question you ask yourself is, does it need to last longer than an hour? And if the answer is, yeah, even though it's not above T10, yeah, it's knee surgery, but they're going to take a while because they've got to drape and they've got to, clean and scrub and re-drape and then change their gloves and then have a shower and then put more gloves on and then start, then it recommends 2 to 3 mils of heavy Prilocaine. And that will cover things like inguinal hernias, ACL repairs, and TURPs, transurethral resections of prostates. But then we come to our final decision, where we don't need a block above T10. It doesn't need to last longer than an hour. And therefore, we come to the final option, which is actually using Ampres. And Ampres is 2-chloroprocaine. And this is for really short interventions, like stripping some varicose veins, having just a look inside someone's knee without any surgical interventions, check cystoscopies, and it'll maybe like a waft of diathermy for those people with bladder cancers and stuff like that. Now, 2-chloroprocaine, probably there isn't enough clinical use to justify a whole extra episode, but this is a very interesting drug because it's the only one that you're going to put in someone's intrathecal space that is an ester as opposed to an amide. This in part is why it doesn't last as long. The advantages of an ester is there's no pseudocholinesterase, or at least very little pseudocholinesterase, in your CSF space. So it's not broken down blisteringly fast. If you were to just inject it in the skin or put it in someone's vein, it actually will get chomped down pretty hard by pseudocholinesterases. So that means that Ampres, you'd have to undergo a Herculean effort to achieve toxicity with Ampres in the doses we're using. There's some interesting bits and pieces on the internet about using it for epidural top-ups because of its blistering onset time. There's a few links in the show notes, and I'll put the data for chloroprocaine in the show notes for this episode, but that would be your really short-acting spinal anaesthetic. But when do we pick a patient to do a short-acting spinal anaesthetic on? Because you shouldn't just do it willy-nilly, because you might end up feeling daft with a patient who needs a general anaesthetic halfway through an operation because you didn't think ahead. So the things that really jump out to my mind is that you should make sure that you have a surgeon who gets on with it and doesn't get trapped with indecision. You need to make sure that the patient is relatively calm and easygoing, and if you were to need to convert to a general anaesthetic, you could manage them without lots of panic and stress. You should make sure that the surgical procedure itself is a simple one, i.e. not a tricky hernia, not a hernia that was incarcerated, now is incarcerated, etc., etc., because you don't want the surgeon to find it more challenging. So it needs to be like a routine, simple operation. And then you also need to be assured that the theatre team is slick and that everyone's aware that you're using a short-acting spinal agent, because Bupivacaine lasts quite a hecking while, which means that there's a lot of room and margin for error. So why are we thinking about using Prilocaine? Because in day surgery, you can turn patients over faster. They get a return of motor function faster, and they can be discharged sooner. Just to give you a bit of a gist about the differences between Prilocaine and bupivacaine, there's a cohort study looking at 60 milligrams, i.e. 3 mils of Prilocaine versus 12.5 milligrams, i.e. a 2.5 mil dose of bupivacaine. Both had additional sufentanil and morphine in because these were for elective cesarean sections. When we're looking at time to return of motor block in Prilocaine versus bupivacaine, Prilocaine was 158 minutes, whereas bupivacaine was 220 minutes. So that's 40 minutes less before they can move their legs again. Now, this was in France, so I don't quite know what their recovery discharge criteria are, but it was 135 minutes versus 180 minutes of PACU/recovery time, but 3 hours in recovery seems excessive. Now, the real information that we're actually curious in is the time to urination when we're thinking about day surgery, and that's because most day surgery units use patient being able to urinate as a discharge criteria, and this is the thing that seems to be the last to return. Although a few places discharge patients even if they haven't peed, but they have quite robust return to hospital criteria and they safety net quite heavily. Now, I couldn't find any robust evidence to really make a decent comparison between Prilocaine and bupivacaine for time to urination, although I'm sure it may exist. If anyone can find that or knows anything about that, please drop me a message or an email and maybe we could add something on. So we've covered quite a lot there. We've explored Prilocaine and touched on 2-chloroprocaine, i.e. Ampres, remembering that Prilocaine is an amide, whereas Ampres is an ester. We've touched on TNS, transient neurological symptoms, something that can happen after spinal anaesthetics and is starkly more common with lidocaine, particularly hyperbaric lidocaine, which is what they were using. And started to consider approaches to patient selection for spinal anaesthesia in order to not end up in a pickle feeling very daft and having to do a general anaesthetic halfway through a procedure, which is far harder than doing it at the start. Anyway, folks, thank you very much for listening. I hope you have a lovely week, and I'll see you next week for... Oh, would you look at that lidocaine? How organised of me. Thanks for listening, guys. I hope you found it useful, but if you found it awful, do let me know. Please like and subscribe, register with whichever podcast platform you find yourself using, and leave a comment if you think I need to square something away. I just want to make sure that you guys know that every day you are getting better at this. There is a bucket of content to try and consume, and it is like drinking from a fire hose. Take it day by day, don't overcook yourself, don't freak out, and keep studying.